Okay, so without further ado, let's get started. Welcome to all the AAPC Hyderabad chapter members. So, as you know that last month session that we have done is on the IVR, and there has been an incredible response, and even on YouTube also we have 1,000+ members has watched and encouraged. So we are here with another session. So now it's time to welcome our speaker for today's session. So we all know he is someone who is already became familiar with uh, much loved name in our chapter events. He is also an officer. So after taking us on insightful journey through the IVR concepts in the last session, he has begun to continue that learning adventure, and this time we are getting deep dive into the vascular world of the lower extremities. So please join me in welcoming Mr. Sheikh Mahaboob Basha, who is a medical coding professional with strong command over the interventional radiology, cardiology, and passion for simplifying complex topics. So we all know, we have experienced it last time. His sessions are known for blending deep technical understanding with the real world logics, making even the toughest concepts sounds very easy and makes easy to grasp. Okay, so we are all set for another vascular adventure of lower extremities. We are exploring the art of IVR coding. Welcome back, Basha. The mic is yours.
Thank you, Sunny. So, hi, good morning, everyone. So, my name is Basha. I'm working for Associate Operation Manager for a reputed organization and also being a part of Hyderabad local chapter. So, today I'm going to discuss about the lower extremity revascularization process and the clinical indications behind it. So, let me share my screen. So, hope it is visible. So, the today topic is lower extremity revascularization. So in which we're going to discuss about the different vascular structures of lower extremity and what are the types of intervention performed, how to code. And webinar of agenda of today's webinar, we are going to discuss about the vascular anatomy of lower limb. That means an introduction to the structure and function of blood vessels in the lower extremities will be provided detailedly. And what are the common vascular disease which may lead to perform the different types of intervention. These also we are going to discuss, and modern intervention techniques. So how we can differentiation these modern intervention technique, what are the benefits as compared to the open surgeries? So while coming to the vascular anatomy for lower limb, what are the major arteries of the lower limb? So here as shown, like the femoral, popliteal and tibial arteries deliver the oxygen rich blood to the lower limb tissue, which are supporting muscles and organ function. When coming to venous pathway, superficial and deep veins such as the great saphenous and femoral veins returns the deoxygenated blood to the heart efficiently from the lower extremity for purifying. So what is the importance of vascular supply here? A healthy vascular system ensures the proper tissue of health, which enables wound healing and maintains overall limb functionally. If there is no proper supply of healthy oxygenated blood to the lower extremity, which may lead to different abnormalities or different pathological disorders. So while coming to the arteries, the entire arteries of lower extremity has been divided or classified into 3 territories. So here we do code based on the territories. Here I mentioned like iliac is the first territory, which is close to aorta. Below the iliac, we have femoral territory. And below the femoral, we have another territory, tibial. So each territory have different arteries again. For example, for iliac artery, we have external iliac artery, common iliac artery, and internal iliac artery. Same way, for femoral territory, we have different arteries like common femoral artery, you can say CFA, and superficial femoral artery, we can also call as SFA. Then profunda femoris artery, which is also called as deep femoral artery. Apart from that, there are some other arteries which I'll mention later in other slides. While coming to tibial, majorly we have four arteries in tibial: anterior tibial artery, posterior tibial artery, peroneal artery, tibio-peroneal trunk. So you can pronounce this anterior tibial artery as ATA, posterior tibial artery as PTA, peroneal artery as PA, tibio-peroneal trunk as TPT. So these are the major arteries. Based on this artery, we do have the code selection as per the CPT. So what are the common blood vessels? So apart from that, do you know any other arteries name which I not mentioned over here under femoral artery? You can write your comment in chat box. So iliac, I know there are three arteries. Tibial also four. In femoral, we do have another arteries names also. If you know, just ping in chat. Are we getting any response?
Yeah, clearly. Profunda femoris.
Yes, yes, it's a profunda femoris. So what are the common vascular diseases we found which may leads to perform any therapeutic intervention? So here, as I mentioned, these are the major. Apart from that, we have many pathological disorders which occurs enter blood vessels. So the main pathological disorder for vascular system is PAD, peripheral vascular disease. So it's a common condition. Generally, whenever the plaque build up inside the arteries, which narrows the artery in the legs, which may cause obstruction to the blood flow. The proper blood flow will not supply to the particular tissue, so which may leads to collapse that area. This is PED, which may require many types of intervention to cure this, like angioplasty, stent. These things we'll discuss in next slide. And deep vein thrombosis. So generally, this deep venous thrombosis, also considered as DVT, which occurs when a blood clot forms a deep vein, most commonly in the legs. So this DVT we can see in lower extremity. While coming to chronic vein insufficiency, this chronic vein insufficiency involves the failure of valves in the leg veins, which leads to blood pooling. So maybe the disorders are different, but the main disadvantage of this disorder is to obstruct the proper blood supply to the lower extremity tissues. So here you can see the pictures also how the peripheral artery disease looks and how the deep venous thrombosis looks, how the chronic insufficiency. These conditions are similar to each other actually, pronounced with different names, with small differentiation. That's it. The common agenda, the common goal for an interventionologist to clear this clot for a proper blood supply. Then we know the diseases. So what are the common interventions or procedures can be done by an interventionologist? That it might be angioplasty and stent and atherectomy. Here you can see a pictures also. This is the the last picture is considered as an angioplasty. If you see, in angioplasty procedure, they use a balloon-like structure to widen the narrow or black blood vessels, which can improve the blood flow. So we have a YouTube channel which is called Nucleus Medical Media. You may get the different types of videos, animated videos regarding this angioplasty and stent. If you have time, you can go through it. We'll write down the channel name in chat box also. Nucleus Medical Media. So all animated videos you will get, not only for IVR, the entire surgery, the 1 to 6 series and part of 9 series you'll get over there. For your better understanding, I suggest those channels. Then stent placements. In stent, So the middle picture is considered as a stent. They will place a mesh tube in artery during an angioplasty to help keep the vessel open long term. So whenever they place the stent, so it helps the blood vessel to keep open long time. So it can enhance the blood flow as compared to previous. Then atherectomy is a separate type of device they use to remove the plaque from arteries for restoring the proper blood flow. The techniques may be different. So what makes physician to choose the technique? It's again the type of clot and the severity of the clot, which may be stenosis or PAD, whatever it may be. Severity and the type of stenosis, which may leads to choose the type of technique by the physician. If stenosis percentage is less, then they can go with angioplasty. If it is stenosis percentage is more like 70 to 80%, then they will choose stent placement probably. So that the decision should be making by a physician only here. Now, if you see over here, you can see the entire arteries name of the lower extremity. To access these arteries, where the physician should do the puncture and enter inside, and which arteries will be considered as a non-selective, which arteries will be considered as a first order. So how many arteries falling under second order? What are the arteries considered as a third order? All these things we can do here. We can see here with the color differentiation. So as we discussed in previous session, the non-selective and selective, how the orders will work, what are the guidelines to follow to code orders. So this is the continuation for that. If you see the access point, which is representing in yellow color, the major access points are common iliac, internal iliac, external iliac, or common femoral. These are the major arteries, major blood vessels. Generally, physician choose to access the point. So once they do puncture here, then based on the side they want to enter or based on the artery they need to do intervention, they will advance the catheter inside. So while coming to non-selective, as we discussed in previous session, aorta is always considered as a non-selective. So the gray color or a little black color we mentioned as a non-selective. So apart from aorta, other arteries are considered will be selective. So what are the arteries will be representing this color? So all are falling under first order. So the purple color will be representing second order. The red colors always considered as a third order. So while coming to the arteries of families, so we have two legs and the same arteries will be present two sides. For example, if common iliac present right side, the same artery will be present left side. So whenever the laterality differentiation is there for based on the anatomical rule, we can append LTRT 50 modifiers to the entire process of lower extremities. Irrespective of any type of technique or any intervention, whether it may be diagnostic or therapeutic, you can append LTRT or 50 modifiers to these interventions. In iliac family, we do have three arteries: common iliac, internal iliac, and external iliac. While coming to femoral territory, we have many arteries: femoral, profunda femoral, lateral circumflex femoral, medial descending branch of profunda femoral, then profunda branches, superficial femoral artery, then superior geniculate artery, popliteal artery, inferior geniculate artery. Then these are the all arteries will be falling under the femoral territory. While coming to tibial territory, here as shown, tibioperoneal trunk, anteriotibial artery, peroneal artery, posterior tibial artery, dorsal pedis artery. This dorsal pedis artery, it is not actually participate for CPT coding of our extremity. Still, it will be present in foot. So I mentioned in anatomical. These are the three territories and the arteries present in each territory. Overview structure and what are the arteries will be considered as a access point and what are the arteries will be falling under first order, what are the blood vessels falling under second order. The complete overview can be given by this picture. So here, for example, as we discussed in last session, what is meant by ipsilateral, what is meant by contralateral? How many of you remember? Ipsilateral, contralateral. You can write your comment on chat box. Okay, good. We are getting proper response. The answer is ipsilateral means same side puncture. Contralateral means they do opposite side of puncture. Same way, I hope you remember the last conversation. How will you differentiation between antegrade and retrograde? What is the difference? You may also comment the same on same in chat box. Antegrade and retrograde. How will you differentiate? Again, before giving the answer, I'm giving a hint. Antegrade and retrograde, while differentiation for arteries it will be different, for veins it will be different. So based on that, you need to provide your answer. Yeah, I could see there is a comment. Antegrade means forward action and retrograde is backward action. This is for arteries or veins. So it will be vice versa, right? For arteries it will be different, for veins it will be different. Okay, I'm getting the responses over here. I can see. Still, I'll give the answer. For antegrade, for arteries, antegrade is definitely the catheter movement will be towards the blood flow. If the catheter placed or advanced opposite to the blood flow, that will be considered as a retrograde. This phenomena is applicable for only arteries. While coming to veins, it will be vice versa. That means towards the blood flow, if the catheter inserted, it will be retrograde. Opposite insertion of catheter to the blood flow is antegrade. So that's it. Thank you. Then what are the CPT codes range we have? As we mentioned that each territory have different set of codes, and based on the type of intervention, the codes has been classified. The code range will be started with 37220 and ends with 37235. If you see iliac territory, we do have 4 codes. 37220 is for angioplasty, 37221 for stent placement, and 37222 it is an add-on code which is applicable for angioplasty done additional vessel for the same side. If the same side they do angioplasty in 2 vessels, then one primary code, one add-on code is applicable. If they do in different laterality side, then 2 primary code or 1 primary with 50 modifier is applicable. Depends on the payer guideline. Same way we have additional code or add-on code for stent if they're done in additional version for the same laterality side, 37223. So while coming to femoral territory, we have 4 codes: 37224 angioplasty, 37225 atherectomy, 37226 stent, 37227 stent plus atherectomy. We do have a combo code. While coming to tibial territory, 37228 represents angioplasty, 37229 is stent, 37230 is for atherectomy, 37231 is for stent plus atherectomy. So someone is commented screen is not visible. Is it for everyone? Okay, I hope it is visible. I can see. Okay, fine. 37232 is angioplasty for additional vessel for the same laterality on tibial side. Then 37233 for atherectomy whenever the physician perform additional blood vessel of the same laterality side of tibial territory. Then 37234 it is applicable to code whenever the physician perform additional stent placement in different blood vessel on the same laterality side again. Then 37235 it's an add-on code we give for stent plus atherectomy combo code when physician perform multiple vessels. So by seeing this picture overview, can you guess something? Anything is missing here or anything you would like to add? Is it looking good or anything you feel weird? There is something missing or some concept or you can comment. Yes. Satish Kumar mentioned like iliac atherectomy is missing. Good. I will tell you the guideline for that. Apart from that, any other? If you see iliac territory and tibial territory, we do have a combo add-on course. If you see femoral territory, we do not have any add-on course. So what if they do multiple interventions in femoral arteries? First thing, there is no code for iliac atherectomy here in the slide. But femoral and tibial territory, we will have atherectomy course. Why? Because the atherectomy course for iliac territory, it not belongs to CPT code range. It is classified under category codes. If you see a code 0238T, 0238T, yes. So this code is applicable for iliac atherectomy, and this we do not have any add-on code for that. If they do, how many arteries we have in iliac territory? 3. If they do 3 atherectomies in 3 iliac arteries, you can code 3 times of the same code. Each vessel, based on the number of vessel, it will be coded. There is no add-on code for 0238T. And why we do not have any add-on codes in femoral territory like tibial and iliac? Can anyone guess the answer? Why we do not have add-on codes in femoral? Because in femoral artery, we do have multiple arteries. Number of arteries will be more as compared to other territories. But still, we do not have an add-on code. What is the reason? Can anyone type the chat box? Same family, okay. That is okay, same family. Yes. So Vishweshwaran given the comment, femoral is considered as a single vessel. For example, let me explain. In iliac territory, we do have 3 arteries. Each artery will be considered as a separate blood vessel while coding. In tibial territory, we do have 4 to 5 major arteries. All 5 arteries will be considered as a separate blood vessel to code. Each artery will be coded separately. While coming to femoral, doesn't matter how many arteries will be present in femoral territory, all arteries will be considered as a single blood vessel for coding guidelines. That is the reason we do not have any add-on codes. Then what if the multiple interventions done in the femoral artery? For example, angioplasty and stent both done in the femoral artery. Obviously, based on the hierarchy, the complex procedure will be coded always. We can code only stent, angioplasty will be included. So that will be given in detail in next slides. See, 2026, yeah, I agree. But if you want to follow the 2026 CPT guidelines, it is applicable from Jan 1st us. So we are in November. So you cannot give the code range for 2026. Definitely will be provided once we reach to the DAS level. So now people are working for November DAS. We are not reached yet to January DAS. That is the reason we are not giving the new codes over here, 2026 codes. Definitely we'll be taking a session based on the 2026 changes. I hope you got the answer. So the only reason, if I add 2026 CPT codes, what is the use of that? We are not going to use, right? So currently we are in November DAS. Yes, Satish Kumar. Atherectomy with stent is high always, hierarchy wise. So these codes, territory wise, I have given classification. Then intervention wise, again, I have given the codes here. So angioplasty codes for iliac artery, initial vessel 37220. Angioplasty for iliac artery, add-on code, we do have 37222. The star mark will indicate it is an add-on code. Same way for angioplasty, a femoral, we do have only one code 37224. We do not have any. Is this season will be posted in any YouTube channel? That the funny will give the details. for angioplasty in tibial territory, we do have two codes, 37228, 37232. One is for primary vessel, second one is add-on code. Same way for atherectomy, for iliac territory, here we can see the code category code 02380. Then for femoral artery, we do have 37225. For tibioperoneal, we do have two codes, one primary, one add-on code, 37229 and 37233. Only stent placement. So generally, angioplasty is always considered as an inclusive part in stent placement. So whenever physician perform angioplasty and stent both in the same blood vessel, then code only stent. So that is the reason I mentioned stent placement with or without angioplasty. For iliac artery stent placement, we do have a code 37221. So for additional blood vessel, we do have add-on code 37223. For femoral popliteal artery, we do have 37226, only one code. There is no add-on code applicable. For tibio and peroneal territory, we do have two codes. 37230 is primary, 37234 is an add-on code. Stent placement with atherectomy. So we have a combo code, 37227 for femoral territory, 37231 for tibial, and 37235 for add-on code. So here, if you see this complete set of codes, again you may get one doubt. For atherectomy, we have a 02380 code for iliac territory, which is falling under category codes. For stent placement, for iliac territory, we have three series codes. If you see in femoral and tibial, we do have a combo code for stent plus atherectomy, right? But we do not have any combo code whenever they perform stent plus atherectomy in iliac territory. So then what we need to do, we can code both codes separately. One is from 3 series 37221. Second one is from category codes 02380. We do not have any add-on code for stent and atherectomy performed in the same blood vessel of iliac territory. So clear this? Then we can see the coding guidelines. So till now we have seen what are the arteries will be present in lower extremity, what are the common vascular diseases, what are the major interventions can be done to cure that, and what is the CPT code range. While coming to coding guidelines, first we need to follow the hierarchy. So hierarchy means always atherectomy and stent placements will take precedence over other interventions, followed by atherectomy, followed by stent, followed by angioplasty. Here I do have a quick question. If atherectomy perform in iliac artery, stent perform in femoral artery, so how will you code? Both are left side. Atherectomy is for iliac territory, stent for femoral territory. Which one you will code as a primary, which one you will code as a secondary CPT? Someone is coded atherectomy only. We can code both. Both are different territories first of all. So hierarchy wise, first we will code atherectomy followed by stent. So another question is here, angioplasty, stent, both will be done in left common iliac artery, single artery, angioplasty and stent both done. So how will you code? Yes, we do code only stent because angioplasty is always included along with stent if they do perform in the same blood vessel. Now, another question I do have, in left side of iliac territory, there are three arteries, right? Common iliac, external iliac, and internal iliac. In common iliac of left side of leg, they place stent. In external iliac, they do angioplasty. In common iliac of left side, they do stent. In left side of external iliac, they do angioplasty. So will you code both or single code? The first. Someone is saying only one stent code. No, we can code both. Why? Because here different arteries, both are. We do have add-on code site. So we can code both. For stent, you can code 37221 as a primary code. angioplasty will be done in different artery, but same side of same territory. So you cannot give angioplasty primary code. So instead of 37222, you can code 37. Instead of coding 37220, you can code 37222 for angioplasty add-on code. If it is same artery, we can code single, otherwise both, right? Yes. So you can code both here in this scenario because the arteries are different. So in iliac territory, each artery will be coded separately. So stenting you can code as a primary code because it's a major intervention hierarchy wise. Angioplasty you can code, but it should be coded as add-on code. So same side, one primary code if you give for one territory, the remaining codes will be add-on code, should be not for primary codes. Clear this concept? Yeah, thank you. Then how we can code if multiple lesions or multiple interventions perform for multiple lesions in the same artery? So the first coding guidelines we need to remember, doesn't matter how many interventions done in a single artery. We do code purely based on the number of arteries underwent interventions. For example, if you take a single artery, left common iliac artery, if they do 50 stent placements also in that artery, you can code only one stent placement code. So the coding guideline says the intervention CPT will be given based on the number of blood vessels intervention, not based on the number of interventions. So in which, for example, in single blood vessels, they do multiple interventions. So the hierarchy wise, which one is complex, that will be given. So remaining the less complex will be included in the more complex procedure. Hope you got this point. Yes, allowed in interventions based on the number of blood vessels. Examples I'll be shown. Later we do have scenarios and examples. There you can see examples. This is this coding guideline I'm giving. Upcoming slides you will get the examples also. I'll give time to track that. Then third coding guideline, code each territory separately. So we do have 3 territories. All 3 territories should be coded separately. For example, if 3 interventions, 3 different angioplasties performing 3 different territories. One angioplasty is iliac, one femoral is iliac, one tibial is iliac. We can code all 3. 3 should be primary codes. Why we cannot code add-on codes here? Add-on code is applicable only if they do multiple vessels intervention in the same territory. If it is a different territories, even in the same leg, all 3 primary codes are applicable. So 37220 is for iliac, 37224 is for femoral, 37228 for tibial family. Yes, Swati, we can code 3 primary codes. So this guideline is clear. Then territory wise guidelines I'll show here. We have differentiation or bifurcate territory wise. While coming to femoral territory, as we mentioned, the entire femoral or populated territory in one lower extremity is considered as a single vessel for CPT reporting. That is the reason we do not have. Yes, Shaun, we have one question. You can type in chat box. Okay. We'll take your questions, will be answered definitely now. So in femoral territory, irrespective of number of blood vessels present in territory, all blood vessels considered as a single blood vessel. That is the reason you mentioned, should we select the most big artery based on the procedure? No. We cannot consider based on the artery. We can consider based on the complex procedure hierarchy wise. So here the code selection is based on the number of interventions performed, not based on the number of blood vessels. Why? Because we do not follow add-on codes guidelines over femoral territory. While coming to iliac territory, so here we do have add-on codes. That is the reason I mentioned the code selection of iliac arteries depends on the number of vessels getting treated. If number of vessels getting treated, that many add-on codes we can provide. So hardly, as per the CPT coding guidelines, one primary code, two add-on codes is applicable for single site. Each artery code separately, one primary code and two add-on codes, not more than that. So while appending the add-on codes, number of add-on codes, I request you to check MU edits. So I hope everyone aware about this MU concept. You cannot exceed the MU edit concept. Then tibial territory. So again, we do have add-on codes in tibial territory. That is the reason the code selection of tibial arteries based on the number of blood vessels are getting treated. Code each vessel separately, and we do have one artery in tibial family which is named as tibioperoneal trunk. This tibioperoneal trunk is not considered as a separate vessel. It is an inclusive part of the antitibial artery and other arteries. That I will be giving the guideline. You will understand. So we do have four arteries: antitibial artery, posterior tibial artery, peroneal artery, tibioperoneal trunk. So apart from this artery, the basic guideline says code each vessel separately. But while coming to tibioperoneal trunk, this artery will not be considered as a separate blood vessel. It is inclusion of other two arteries, which is called peroneal artery and posterior tibial artery. That I will give example, you will understand. So what are the bundle services in this 372202 to 37235 codes? So catheterization, if they do perform, it may be selective or non-selective, that is inclusive. Then in last session, we have discussed radiological SNI, supervision and interpretation, 7 series code, that is also inclusive. Then embolic protection, if used, that is also inclusive. If they do arteriotomy closure, if applicable, that is also inclusive. So these procedures are percutaneous or open approach procedures. Can anyone say? Both, yes. So this is the only topic in IVR we do have. We can accept if it is performed both in open or percutaneous. That is the reason arteriotomy, if they do also, while completing the procedure, they do arteriotomy closure. That is also applicable. So if physician is performed, doesn't matter approach, percutaneous or open or endovascular, same set of codes are applicable. This is the only topic in IVR we do have. We can code 3 series for open approach. Then imaging to the document completion. Any imaging guidance they use, that is also. Yes, Satish, you do have one question. Please ask. So I'll give one scenario based on the guidelines we discussed. A 80-year-old with left leg claudication, he do have a claudication. Year-old with left leg claudication. A catheter is advanced from the right groin into the left common iliac artery. So right groin to left common iliac artery. So which type of approach it is? Ipsilateral or contralateral? Contralateral, yes. So enter into the left common iliac artery and left leg angiography is performed. 5 separate stenosis in the superficial femoral and popliteal arteries are seen. 5 angioplasties performed for these 5 stenosis. So where in superficial, femoral and popliteal, total 5 angioplasties, all 5 stenosis having 80%. So now what you will code? How will you code? Can anyone suggest your answer? There are 5 angioplasties performed in 2 blood vessels, and 5 angioplasties we have medical necessity. There are 5 lesions which is having 80% of stenosis. Number of lesions treated. Karthivel Chinnaswamy. Someone says 2. Uday Kumar Reddy. Bharati 37224, Sagar, Chandani 2. 2 means what? 2 angioplasties will be coded or what? So what is the coding guideline for femoral territory? Irrespective of any number of blood vessel, will be coded as a single code. We cannot code 2 angioplasties, only 1 angioplasty. 37224 is the code. See here, the rationale will be provided. Code angioplasty per territory treated, not per lesion, as this is in the femoral populated territory. Catheter placements and S&A are bundled. So we can code 37224 along with the respective laterality modifier. If it is left side, you can code LT. If it is right side, you can code RT. Clear? As per the guidelines, we know CAP inclusive with lower extremity revascularization procedure. Can we code 36140 separately with 59 modifier for initial aortic common femoral access? See, in this case, the intervention is completed. Then no need to code 15 modifier with 36140. Then the second scenario, via an antegrade approach, angioplasty is performed of superficial femoral artery, popliteal artery, and antitibial artery and postitibial artery, which is having stenosis. Total 4 arteries. One is femoral artery, second one is popliteal, third one is anterior, fourth one is posterior. These 4 arteries have stenosis. These stenosis are separate, distinct, focal, and severe in nature. So they have done angioplasties for all these 4 arteries. How will you code? First, these 4 arteries you can divide it into territories. Superficial femoral artery and popliteal artery, single territory. Antitibial artery and postitibial artery, both are falling under same territory. So again, territory-wise guidelines. Femoral artery, popliteal artery, even different arteries, but will be considered as a single artery because it is falling under femoral territory. In anterior tibial and posterior tibial, both arteries will be considered as a separate blood vessels. Video had on course. Now tell me the codes. 226. Why 226 is not a stent code, right? Sorry, it's not a angioplasty code. Someone coded 37224, 37228, and 37232. Shruti MK. Only 37224. Why? What about other arteries? Kari 37224, 37228. So 228 is applicable for one artery of tibial. Then what about another artery? You can code add-on code, right? Yes, you can code 37224, 37228, 37232. Then the scenario 3, via cut down and after dissection and vessel loop placement, a catheter is advanced across an iliac stenosis into the aorta. So angioplasty with an 8 mm balloon angioplasty is performed for iliac stenosis. So via cut down, that means it's an open approach. They have done the layered closure. Balloon angioplasty performed for iliac stenosis. So how will you code? Iliac stenosis, iliac is not 2 to 4. Iliac 2 to 4 is for femoral. Someone coded 37221, that is 10th placement for iliac. Angioplasty for iliac is 37220, right? Even it is cut down of artery, then closure, laid closure they done, doesn't matter. Falling under open approach, still the same set of code we do follow. 37220. So the rationale has given like codes 37220, 37235 are open or percutaneous approach catheter placements. SNI and closure of the incisions are bundle always. So the respective modifier you can give it. So I'll be reading the question. So you can provide the rationale with answers in chat box. A 60-year-old male undergoes surgical cut down of the left common femoral artery with placement of a silver hack atherectomy device down to the popliteal artery. Atherectomy is performed an eccentric plaque in the popliteal artery. A cross catheter is then used as an atherectomy device to recanalize a total occlusion occluded in posterior tibial artery. Total how many atherectomies and how many arteries, how many territories are involved, apply the coding guidelines, then tell me the codes.
Muhammad Basha, if you put your WhatsApp group promotion again, we are going to remove you from the conversation. Do not put your personal promotions in the chats. Okay. Do not do it again.
I'm sorry, I'm talking in mute. So another questions I do have here. If physician is perform 2 atherectomies, one is left common iliac artery, another one is left external iliac artery. How will you code? Based on the coding guidelines, you can provide the codes. Atherectomies, one is left common iliac, another one is left external iliac. You can see one answer 02380 into 2. So you cannot code as a units, this 0 category code. So any other answers? The code is correct, 02380. 37225 we cannot code. 37225 is for femoral artery, right? So I'm asking about iliac. Yeah, 02380, 59 modifier. So you can code 02380 2 times. So whenever you're repeating the same CPT, the 59 is applicable. So here you can code excess modifier to consider as a separate structure instead of 59. 02380 2 times. For one code, you can code either 59 or excess. So one more questions I'll ask. Physician is perform. So this question is very important actually. There is a hidden coding guidelines in this question. Please listen. If physician is perform angioplasty in anterior artery and posterior artery, 2 arteries, both are same side. Anterior artery, posterior artery, both are underwent 2 different angioplasties. Tell me how will you code? Will you code both or one? If you code both, what are the codes? Yeah, I can see both, many of them even. 228, 232. Yes, the both vessels will be considered as a separate arteries, even in the same territory. Now, same question I'm changing somewhat. One angioplasty in posterior artery, the another angioplasty is in tibioperoneal trunk. One angioplasty in posterior tibial artery, another angioplasty in tibioperoneal trunk. Both are left side. Will you code both or single? So someone says single, someone says both. If it is single, why single? Each artery should be coded separately, right? In tibial territory. Then both are different arteries. Why we can code single? Can anyone answer in chat box? Same part, Viswesharan. PT areas from trunk. Okay. Satish Kumar. Tibioperoneal trunk is inclusive. Resma. Okay. Lavanya, same side. Same side doesn't matter here. The guideline says this tibioperoneal trunk is not considered as a separate blood vessel from tibioperoneal trunk, peroneal artery and posterior artery. That is the reason we cannot code separately. We can code same. Now another question in the same code range. There are 2 angioplasties again in tibial territory. One is antitibial artery. Second one is tibioperoneal trunk. One angioplasty is in anterior tibial artery. Second one is tibioperoneal trunk. Now, will you code both codes or a single code? Chitra Maurya, you have coded 2 codes. Maria, 2 codes. Periyaswamy, single code. So why it is single? You applied the same guidelines for the last question. No, here the guidelines are changed. You can code both. I'll tell you the guideline. The tibioperoneal trunk is always considered as a same blood vessel from peroneal artery and posterior tibial artery. These 2 arteries only. But considered as a separate blood vessel from anterior tibial artery. So whenever they do anterior and tibioperoneal trunk, you can code both. Instead of anterior tibial artery, if I mention either peroneal artery or posterior tibial trunk, then you can code single code. So that is the coding guidelines we have for tibial territory. Understood? Okay, done. So then we'll move to the next slide. So we can ask another question over here before entering to the next slide. Common iliac artery, left side angioplasty. Same right side, common iliac artery angioplasty. Will you code 2 primary codes or 1 primary, 1 add-on code? Will you code 2 primary codes or a primary with add-on code? Code with 50 modifier, someone saying, someone tells 37220 RT and LT, okay. Periyaswamy, 2 codes, 2 primary, okay. 1 primary with 50 modifier, yes. So, okay, you cannot code add-on code because the laterality is different. You can code either 2 primary codes with LTRT modifier or single code with 50 modifier. Again, this is your, based on your client specific. Some clients will accept 50 modifier, some will accept RTLT with different codes. So, based on how they are getting billed. Now, another question. Left side posterior tibial artery angioplasty, right side tibioperoneal trunk angioplasty. Left side posterior tibial artery angioplasty, right side tibioperoneal trunk angioplasty. Will you code both or single code? Yeah, you can code both codes. Why? Because the lateral is different. Even the tibioperoneal trunk is inclusive part of posterior tibial artery that is applicable for the same side. If it is different side, you can code both. Now, another question. Stent placement in common femoral artery. Stent placement in common femoral artery. Angioplasty in superficial femoral artery. Stent in common femoral. Angioplasty superficial femoral. Both are same side, left side. Will you code both or single? Shaun said code both. Vishweshwaran only 1 code. Sanket stent only. So in femoral artery, irrespective of number of arteries, will be considered as a single blood vessel. So both arteries are single blood vessel. So most hierarchical procedure will code. So all code only stent. Angioplasty is included. Got it? This phenomena or guideline is applicable only for femoral arteries. Okay, another question in the same manner. Superficial femoral artery. Make a note. Superficial femoral artery, they have done stent placement. Common femoral artery, they have done atherectomy. In popliteal artery, they have done angioplasty. 3 different blood vessels of same territory, 3 different interventions, stent, atherectomy, and angioplasty. Now, which one will go? Someone says only atherectomy, someone says atherectomy and stent. Atherectomy with stent, we do not have any combo code, right? Why will code atherectomy with stent? Generally, what is the most hierarchical procedure complexity wise in these 3? Atherectomy. So, in irrespective of number of blood vessels, will be considered as a single blood vessel. So, code only atherectomy. We do not have any combo code for stent and atherectomy here. So, category codes, they will take precedence over this CPT code range in this lower extremity. Okay, moving to the next slide. So, whenever you are coding lower extremity revascularization, you may get another terminology, intravascular ultrasound used. Intravascular ultrasound. So, what is meant by intravascular ultrasound? Intravascular ultrasound, generally they use an over-the-wire vascular catheter with ultrasound capabilities to record the ultrasound pictures of the blood vessels. So for ultrasound, if you added intravascular inside the blood vessels, that is called as intravascular ultrasound. So same imaging guidance, they will apply the concept inside of the blood vessels. These procedures requires a special equipment and monitors. We need some expertise and personnel to perform it. So it is an adjunct to angiography and may be used to help plan evolute. So you may get doubt, already physician is performed angiography to get the images, then what is the use of IVUS? What is the clinical indication behind that? That I will tell. It is an adjunct to angiography and may be used to help a plan, evaluate and determine the success of vascular interventions. So which may give the additional benefits or additional information to the provider to get the more about the vascular diseases which are uh, inside the blood vessel. So coding is per blood vessel evaluated. Generally, these intravascular ultrasound they'll be done whenever the patient is having DVTs and some atherosclerotic diseases in lower extremity. Here you may get the clinical indications. What is the clinical indications behind it? To get a real-time visual imaging, to assessment and guidance, to improve the outcomes. So generally, this intravascular ultrasound provides live detailed cross-sectional views of blood vessels using a tiny ultrasound probe as shown in the picture. This helps to visualize the vessel structure accurately. So if you do angiography, you may not get the results very accurately, but to get additional information, to get to know the about the conditions which is present inside the blood vessels, the physician will use this real-time visual imaging. This is called intravascular ultrasound. Then assessment and guidance. So these IVUS assist in measuring the blood vessel size, identifying the plaque composition, how it has composed inside the blood vessel, and guiding the physician for interventional procedures for precise treatment and planning, very accurately and precise treatment. To find out the condition accurately, to perform the procedure very precisely, this ultrasound will be used. So based on that, the outcomes will be improved. What is that? Using IVUS in procedures, which improves the decision making, which enhance the results. If you know more about the condition, so you can take a decision very wisely, right? So that is the reason the physician will use IVUS, and which helps to reduce the complication for better patient care. So it's a device which will be entered into the blood vessels. So there is no more complication while using this. Yeah, someone is saying, do we need to post our credentials here in order to get CEUs? No. While registering only, we'll get capture. So based on the registration, we'll provide the CEUs. From here, we cannot take, there are hundreds of messages we are getting right in chat box. So while register itself, you need to enter the details. So we'll get automatically the data. So what is coding instructions? We have only two codes, 37252, 37253. These two are add-on codes. Must be reported with a base code. Either it may be diagnostic or therapeutic intervention. So this should be coded for each vessel. Number of blood vessels underwent IVS 37252 to one code. The number of units you can code 37253. Then if it is, for example, there are 10 blood vessels in the same artery, same left side, you cannot code 37253 into 9 units blindly. Before entering to the number of units, please check the MU edits. So for physician, it will be different. For hospital coding, it will be different, the MU concept. You will get in any leading to 3M or select coder, encoder, whatever. So I'll give a scenario. 70-year-old male with an abdominal aortic aneurysm presents for evolution. Patient has had abdominal aortic aneurysm AAA, which is called AAA, aortoiliofemoral angiography. So the combined angiography from aorta to iliofemoral level they have done initially, and IVUS catheter is advanced to the aorta. So intravascular ultrasound, they will advance to the aorta, and aortic IVUS performed, as well as IVUS of the entire ipsilateral common iliac artery. Same side for common iliac artery also, they have performed IVUS. So we do have two codes, 37252, 37253. First the IVUS done in aorta, then common iliac. So before that, they have done aortoiliofemoral angiography. There is no therapeutic intervention done. Diagnostic angiography performed, after that IVUS to get the results. Now how will you code? So codes does not require 252, 253, 75710. So what about our abdominal aorta angiography? Yes, Masrat 36200. We can code. So SNI code also we can code. SNI is inclusive for therapeutic intervention. If it is diagnostic angiography or IVS, the SNI code will be coded separately. Four six two five three. Why 4 series came in picture? Anusha Chandana. 4 series 253. Why 46253? For what purpose? IVS primer and add one code. No, what about orthography? 75630, okay. So here you can see the answer. For aortography, you can code 36200, 75630 SNA code. For aortoiliac angiography, 37252 and 253 is for IVS. So why we did not code 75710 SNA of lower extremity? Because they are not doing any angiography in common iliac artery. They are doing the combined angiography for aortoiliac femorography. That will be coded as 75630. So 252 for primary blood vessel, 253 is additional blood vessel. Yes, Satish, you have doubt in this scenario, tell me. So we do not have separate code for aorta and iliofemoral artery for single side, right? So you can code 75630 only. Yes, Satish. So we do have only one code, 75630. Even it is unilateral or bilateral, doesn't matter. We can code 75630. Whenever physician perform aortography along with iliofemoral. So any doubts you can ask in question and answers will be given. Yes, if it is single catheter or multiple catheter position doesn't matter. For aorta along with iliofemoral, you can code 75630. So another one is Ashwani Sharma. Vascular tertiary concept is only for arterial system, right? Venous system code categorized based on the each additional. Yes. So we are discussing about completely for arteries. For veins, you said we do have only hardly 4 codes. That is based on the number of blood vessels. One primary, one add-on code. This answer is for Aswani Sharma. So under question and answers, you can raise the questions. So another question is, if atherectomy and stent placed in iliac artery, then we can code both. No, we have a combo code, right? Sorry, iliac. Yeah, iliac you can code both. Because in iliac, we can consider as a, we will code based on the number of blood vessels. So another question, radiological SNDI is inclusive in lower extremity revascularization, but if the intervention is based on the decision after imaging, can we code both 7 series codes, right? If physician is already had a findings based on the angiography code, then 7 series no need to code at all. It will be inclusive only. The current findings you can code. My CV is also not created for last 2 webinars. No, we have added all CVs. It's showing in our data. You may enter, someone are entering the wrong ID number. I don't know exactly. Funny will be answer for these questions. Link for survey. What survey? Okay, these are the coding guidelines we need to follow for lower extremity. It's a simple and single topic. And if you raise the questions and based on the scenarios, if you practice for number of scenarios, you will be get good knowledge on this. Over to you, Funny.
Thank you so much, Basha. You can stop sharing your screen. So, hope the session is helpful to everybody. If you have any questions, we can use this time to address your questions. So, please do ask your questions. I would be looking at the Q&A uh, piece. So, the question, Basha, that we have received is, what modifier commonly used in IVR along with 7 series?
Generally, RTLT we can use. Apart from that, you can use XU modifiers. For 7 series, you can use XU modifier and RTLT, 50 modifiers, XU modifiers. These are the common modifiers we can use. 26 generally in IVR, we don't apply. We apply XU and laterality modifiers only.
Thank you, Basha. So there is another question. Atherectomy performed in peroneal artery, tibioperoneal trunk, and PTA. How we will code?
The question.
Atherectomy performed in peroneal artery, tibioperoneal trunk, and PTA. How we will code?
So PTA, tibioperoneal trunk, peroneal, three different arteries, three atherectomies, and tibioperoneal trunk is always considered as a inclusive component. So remaining two, one primary code, one add-on code for tibia family.
So there are many questions regarding the CEUs, and we have always been mentioning you should not post your personal details in the chat box. You don't need to provide your AAPC ID, your email ID, and all these things in the chat box. So we will auto capture your attendance, and based on that, the CEUs will be awarded for all the previous events. Who are all the eligible members, who are all the people who has joined for at least 90% of the time. So the CEUs were already awarded to them. So please ensure that you stay till end of the session at least 90% of the time. So you will get the CEUs for sure. And so we did observe like few of the members are reaching out to us that the CEUs were not added, but our attendance tracker is showing the CEUs. So for such cases, we would request you to reach out to AAPC support uh, chat so that they will help you with the technical issues, whatever that you are facing about not seeing the CEUs. Okay. So that is one thing, and even for this particular session also, you don't need to share your details. So I see a lot of the members are putting your details here. You don't need to share any details. We will add the CEUs also automatically from the backend based on your attendance. Okay. So there is one question for you, Basha. Can you please clarify when and when not to use 76937 CPT?
76937.
Yeah. You can take a minute to look at the code.
See, this 76937, it's an add-on code actually. Generally, this code used while accessing the catheter after puncturing, if physician take the help of ultrasound guidance to evaluating the potential access, then only we can code 76937. And you need to get the real-time images in the documentation that word. So the needle entry, puncture site, access site, and physician is perform ultrasound for getting before accessing the catheter in the site, then we can code 76937. The real-time imaging should be documented.
Thank you, Basha. So we have a question from Nitin. Can we get a PDF notes? Yes, we will upload the PDF of this presentation in the LinkedIn. So I hope you are all following the LinkedIn and WhatsApp channels. We will post there. There is one more question from Saurabh Basha. When atherectomy plus stent was done, and we are only coding for atherectomy, how is stent being reimbursed?
See, here based on the coding guidelines, if all blood vessels, this question is not for not applicable for all arteries, all territories. If it is iliac territory and tibial territory, we can have a combo code. You can code different codes. It will be get reimbursed. The question is coming for only for femoral artery. So if all arteries considered as a single blood vessels, so doesn't matter if they do multiple intervention, the hierarchy wise, the complex one should be coded. So based on the coding guidelines, we need to follow. If it is not getting reimbursed, then we can send the rebuttals with our coding guidelines. The femoral blood vessels, all blood vessels considered as a single blood vessels, the most hierarchical procedure should be coded always. That is a basic coding guideline. You cannot skip the coding guideline for getting reimbursed, right?
Thank you, Basha. So we have one more question, Basha, on the selective catheterization. So selective catheterization for celiac artery and selective catheterization for SMA and intervention performed. Then how can we code? Please explain.
So celiac and SMA both are first order family, arise directly from aorta. You can code 36245, 36245 two times with excess or 59 modifier.
Thank you, Basha. Someone mentioned look at the Q&A. Everybody is spamming with the CEU question so that we are not able to see the actual thing.
So another question I can see, can we append RTLT modifier for hepatic arteries? For diagnostic purpose, it is not required. It won't get effect for your reimbursement. If it is for lower extremity, you can append, but for hepatic, it does not require.
We will be uploading the recording in our YouTube channel, Hyderabad local chapters YouTube channel. So you can go through it whenever it is needed. All right. So Muhammad Basha, whoever is posting about this WhatsApp invite, this is the last time we are going to remove you.
Right. Your question this one.
Yeah. No, there is no link to fill the attendance. You don't need to fill. So yes, Basha, you can take.
So another question from Banu, how to decide when to code 75630 and 75625 plus 75710. So all these three codes are SNA codes, Banu. Whenever physician perform angiography, we can code this 75710 if physician is perform angiography in one side of lower extremity, either at right side or left side, you can code unilateral 75710 with RT or LT modifier. 75625 is for only abdominal angiography. If physician is perform abdominal angiography with iliofemoral, with the help of the advancing the catheter from aorta to, along with aorta angiography, if physician also perform iliofemoral angiography as a runoff, then you can code 75630. Even it is a single lateral or a unilateral or bilateral, doesn't matter. Same code is applicable. And laterality modifier applicable only for 75710, not for other two codes.
All right. So there is no link to fill the attendance. So while you are registering, we have already captured your information. So there is no link. All right. So I think that's the end. I'll just look at one more time. Look at this one more time and see if I can find any questions. Hmm.
Here another question: if IVUS intravascular ultrasound perform in the aorta, common iliac and external iliac artery on the same side, how do we report? So here we need to check. Aorta is completely different. You can code 37252. While coming to common iliac and external iliac, we need to check the common external iliac is a continuation of the common iliac or it's a separate branch of common iliac. If it is a continuation, definitely one code is enough. If it is a branch of common iliac, then two codes we need to get. So I'm looking into the picture. I'll tell you. So common iliac and external iliac both will be considered as a single bed vessel for intravascular ultrasound, not for interventions. So you can code 37253 only once. It's a continuation. Same artery, based on the location, the name will change. In case of external iliac, if physician perform IVUS in internal iliac, then definitely you can code 37253 into 2 times. So you need to check the picture of the lower extremity arteries. The same vessel is continuing down or it's a branch. If it is a branch, then only additional code is applicable. If it is a continuous, then you can code a single code. So this question raised by, I cannot see the name, by Masrat. Yeah, I hope you got the answer, Masrat. Then another question: celiac catheter and angiography performed, angiogram. Also SMA performed without intervention. Shall we code 245, 245, 59? Yes, you can code 75726 and 75726 with XV modifier. Yes, correct only. Then if angiogram and catheter placement on same location, same day, how to follow the procedure? Didn't get the question. If angiogram and catheter placement on same location means what? So any other questions? Checking here. Do we require renal artery findings along with aorta to bill 75625? Not required. If it is documented also, the code will not change. This code is applicable for aortography. Then again, Masrat. So common iliac, internal iliac, we can consider separate bed vessels. Yes, you can consider separate bed vessels because if you see the picture of lower extremity arteries, the internal iliac is a branch of common iliac. So we can code separately. Can you provide ICD-10 CM 2026 PDFs? Okay. What is a vascular family? Vascular family means the entire arteries and veins will be considered as a vascular family from top to bottom of human body. The all arteries. Any other questions?
All right. Thank you, Basha. Thank you for your wonderful session. So before we talk the closure, I just wanted to um, say thank you for all the members who are joining the session and would like to do a quick check. How many of you are recently certified, maybe like a month ago or within this month? How many of you are recently certified? And we see many of the members are very much recently certified. Yeah, myself, many members are coming. I know, like, so we have been getting calls. So these sessions for the guys who are freshers, who are very new to these. So you need to ensure that you are attending the sessions like these from the local chapters to earn the CEUs. So CEUs requirement will be there for every 2 years. You have to meet a certain number of CEUs to keep your certification active, and this helps you to get updated with the up-to-date knowledge as well. So whenever these kind of sessions are happening, you need to attend these sessions and gain your CEUs. And at the end of some period, so you can check the CEU trackers in your AAPC logins. So at the end of this period, you will have to submit certain number of CEUs. If you didn't submit, then your certification may be at risk. So please ensure that you attend the sessions, and also please ensure that you are cascading this information to your friends who are not attending, who are not aware, who has been your classmates when you are learning CPC or something. Okay, so just mention this to everybody. Okay, and for all of the sessions that you are attending, we are adding CUs. We have already added CUs from the backend. Here you don't need to collect the CUs from anybody. You don't need to do anything from anybody. And one important thing that I wanted to mention, because it is coming to our notice, that people are buying the CEUs from various different people. Buying the CEUs from different people is not an official thing, it is an illegal activity. And AAPC does audits on whatever the CEUs that you are submitting, and AAPC will punish those people, and AAPC will ask for the verification and everything. So please ensure that you earn the CEUs on your own legally by attending these kind of sessions. Okay, so very, very important thing. Is this clear to everybody? Just give a quick thumbs up. Yeah. So anybody who is an AAPC member, can be from which any local chapter, can attend. Okay, you can attend. All right. So with that, we are. I'll hand it over to Srinivas to convey the vote of thanks. Over to you, Srini.
Funny. Thank you. Can you hear me? Funny.
Yes, Srini, you are audible.
Yeah. Great. So, special thanks to our speaker, Basha. So, it's a new topic for me, even with our 10 years of experience in medical coding. And this was such an insightful and interactive session. Thank you so much, Basha, for your insightful session. And thank you so much, everybody, the local chapter, to have this session. Thank you, Fani. Thank you, Harish, Adi ma'am, and Madhuri. So, when I've started, last month of this particular session, it is useful for me because I didn't know this information because I'm into a different, department in the medical coding. Such a wonderful session. And at the end, I want to, of course, I want to thank Basha and I want to thank everyone in the meeting. And regarding CUs, as Funny has already mentioned, so you'll be getting your CUs, probably by November 25th. So one thing I want to mention that if your details are incorrect, we'll try to give you CUs by finding, by fitting your details like name and your, member ID. However, if your details are completely mismatching, I think we may not be able to help you out. Please reach out to us with your details again. But so as Funny has mentioned, we'll be giving your CEUs as soon as possible by capturing the time that you are spending on this particular meeting. So with that, thank you so much, Basha, again, and everyone. Thank you. That's all from my end, Funny.
Thank you, Srini. Yes, so I also wanted to add one more thing at the end. So we will be like, we all know that. So 2026 CPT updates are coming up with a bang. We know the IVR is major area of concern, and there are major changes are coming on the IVR piece. So we will try to conduct a session in the month of January with all these updates with the maybe with Basha or any other expert whoever gives us some time, because we wanted to share this knowledge with everybody. So let's continue this spirit of learning and growing together as a coding community. Until our next event, stay curious, keep coding, and see you soon at our next AAPC Hyderabad local chapter session. Thank you all for joining today, and thank you very much. Bye bye.
Thank you.